Assalamu alaikum wa rahmatullah, and thank you very much, all of you, for joining our meeting today, webinar about the updates in pressure ulcer prevention and the future scope. And this is Abdulkareem Iblasi, and this event already organized and supported by النداء جروب. دكتور سامر السلام ورحمة الله. دكتور سامر اتفضل. The stage for you دكتور سامر. we are waiting.
شكرا للدكتور الكريم على المقدمة. بداية أنا سعيد جدا أن أكون اليوم في هذا اللقاء. بالمناسبة مثلا نحكي لكم شوي عن النداء الصحي أو Health Civil Society. أوكي، حقيقة النداء الصحي هي جمعية صحية أردنية. الفكرة منها هو العمل الطبي الخيري، العمل الطبي الخيري بجميع أبعاده، إن كان على مستوى الخدمات الطبية للناس الفولنربل، تمام، وبالإضافة إلى بناء القدرات. حقيقة الجمعية بتأخذ منحى شوية هيك على موضوع بناء القدرات. فالحمد لله رب العالمين خلال ال4 سنوات الماضية قدرنا نعمل برامج نوعية وفرناها للكوادر الصحية إيفن جوا المملكة ولا المملكة الأردنية الهاشمية ولا خارجها، تمام. طبعا على أيدي ناس نفتخر هم موجودين معنا في الجمعية كمتطوعين. قدرنا نوصل لأكثر من 400 ممرض وطبيب وفني رعاية صحية إن كان تخدير أو غيره، بفضل ربنا. طبعا عندنا شراكات جميلة جيدة ونفتخر فيها مثل الجامعة الأردنية وجامعات أخرى تشرف على إصدار شهاداتنا. طبعا هذا كلياته ضمن القالب الخيري، لأن كل البرامج تعقد ضمن النمط الغير ربحي. هنا شويه بدي اعرج على الشراكات وعلى التطوع وعلى العمل الخيري. بجوز شويه هيك الناس بتضلها يعني كونفيوز من موضوع ايش هو التطوع. بعد اذنك دكتور عبد الكريم.
تفضل. And also Dr. Samir, we have non-Arabic speaker in the webinar.
We encourage الناس اللي زي عبد الكريم، طبعا مشكور بخبرته بعلمه، تمام، ايوه، يطوعوا بحيث انهم يطلعوا زكاه علمهم. يعني احنا بنحكي دائما للدكتور عبد ما شاء الله عليك يا اخي، الناس لها عليك حق، زكي، فتطلع الزكاه في زكاه العلم اللي احنا استثمرنا فيه، وهي زكاه دائمه، وهي من افضل الاعمال الخيريه التي يقوم بها الانسان، وعلم ينتفع به. طبعا زي الدكتور عبد الكريم، في عندنا الدكتور علي العموري من الجامعه الهاشميه، في عندنا الدكتور محمد ملي مصطفى وغيرها من الاسماء اللي فعليا حقيقه بعمل خيري عظيم جدا ساهم في بناء او خلينا نحكي ببناء القدرات للكوادر الصحيه ونشرها. اليوم احنا مع الدكتور عبد الكريم في موضوع مهم جدا، وهو الابديتد في البريشر ألسر، تمام. نشكر الدكتور عبد الكريم على هالمحاضره القيمه وهالابديت تبعه. طبعا احنا زي ما تفضلت احنا هيلث ابيل سوسايتي، جمعيه النداء الصحي، جمعيه اردنيه. الويب سايت تبعنا www.healthabil.org. بنرحب باي استفسار، جاهزين للتعاون مع اي شخص. هدفنا هو نكون اوفرسيز بالمنطقه وبالاردن، سبيشالي في بناء قدرات الكوادر الصحيه. مره ثانيه شكرا دكتور عبد الكريم، شكرا للاخوان الحاضرين، اخذت من وقتهم شويه، سامحوني على الاطاله ويعطيكم الف عافيه.
Thank you very much, Dr. Samer, for this kind event and for this kind and your effort and cooperation. And as Dr. Samer said, it's really a very interesting aspects that we will go to discuss and present the new updates about what happened in the current evidence based regarding to the pressure ulcer and mainly the pressure ulcer prevention, and why this issue already start to develop. Now we were remembering that in 2 years almost now, before 2 weeks I think, the WHO announced that COVID-19 is not a pandemic, and all the story of the pressure of the COVID-19 end in 2 or 3 years around. But the pressure ulcer still it's happening. It's still a pandemic that already affects all the hospitals, and still its continuity. And even with all evidences that we have, still the pressure ulcer is making a problem. We are going to present the new updates happening regarding to the pressure ulcer prevention, especially about the new talking and what's going on regarding to the new pressure ulcer guideline and how that pressure ulcer aspects already start to change our attitude and behavior about the pressure ulcer. We agree that pressure ulcer, or the name in the North America and Canada, it's pressure injury, already it's preventable in more than 90 or 95% of the current situation, already preventable. But the problem that still we have pressure ulcer, and we say that this pressure ulcer is preventable, but we failed, or the healthcare system already failed to prevent this. And that make us to ask a question: why that still happen? Is there a problem regarding to understanding our knowledge or utilization for these aspects? Where is the gap between the evidence and the application? Now, if the pressure ulcer already prevented, and we already know that the evidence, or we have the strong evidence about this prevention, so why this problem still happen? Just to remind you, when we are talking now about pressure ulcer or pressure injury, that still there are a lot of alternative names still used in the hospital, even some of them already old but appear in some hospitals, such as bed sores, decubitus ulcer, pressure damage, pressure injury, pressure sore. All these terms still used in publicity. To remind you about the last definition for the pressure ulcer, and we already understand the differences, situations between the different school of thoughts regarding to defining is it pressure ulcer or is it pressure injury. And we agree that still in the region or the Middle East here, all they are much more influenced in the term of a pressure ulcer instead of pressure injury. And in general, we are so much happy about the cooperation happened between the European Association and the North America Association and Pan-Pacific Association about agreeing on unique one definition for the pressure ulcer or pressure injury. And just for reminding, we are talking about localized damage to the skin and or pressure due to the pressure with shear, and this occur even also from the medical device related pressure ulcer. Now, the term already evolved, and within this evolved and the changes happen in the term, our understanding for the prevention is still facing the same challenges. Since the time of Florence Nightingale, we already send our regards and appreciation for her efforts and for all nurses all over the world. And we are now celebrating the nursing days and nursing weeks. Since the time of Florence Nightingale, there are some agreements about the pressure ulcer prevention. All these preventions already supported by the evidence, supported by the care regarding to the prevention, understanding which patient already under risk and what we should do to prevent this risk. And this is something start to happen in the hospital in daily basis. We remember what Florence wrote before around 200 years, that if he has a bed sores, it's generally not a fault of disease, but the nursing, or it's a fault of the nursing. So the prevention is the key. And since 1987, when we have the National Pressure Injury Advisory Panel, which was before National Pressure Ulcer Advisory Panel, and we have the idea or understanding that the prevention is the key. And we agree about this one regarding to the cost of the pressure ulcer, the consequence of the pressure ulcer, the economic burden for the healthcare system all over the world regarding to the pressure ulcer. And we know and discuss the famous study come from Saudi Arabia, which already count the total cost of the pressure ulcer. And I think this study now may be more than 9 years since it already started. And in that study, they calculate the cost of a treatment for the pressure ulcer on that particular hospital in Riyadh. And they estimate the total or the cost of pressure ulcer on stage 1 to be around 6,100 riyal, which is around 1,000 pounds. And this cost of the pressure ulcer already increased until it reached around 143,000 Saudi riyal, which is around 22 or 23 pounds. And this study already taking consideration some other facts already. Maybe now it's outdated, maybe the cost now it's already increased. And within this frame, we understand the complexity of the pressure ulcer, that it's something not only depending on what the nurses know or what the people already responsible, they have the knowledge or skill, a risk assessment, diagnosing, staging, and treatment. Until now, we already agree about the general principles about why the pressure ulcer already developed and the role and impact of the prevention to minimize and stop that from happening. So it's all part of the pressure, and this pressure, how much it already compressed the blood supply. And this compression happening to the blood supply first in the first hypothesis, manipulate the ability of the tissue and will lead at the end to the death of the tissue. Regarding to the changes in the skin care, regarding to the changes, all of this still are following up the same idea of the need for offloading the pressure until we have the pressure ulcer prevention. So all of that it's already known for us. We already able to to count this need, and we know the need for the pressure ulcer prevention. The nurses, the studies already shows that we don't have this significant issue about the knowledge of the pressure ulcer. Even that there are hundreds of educational activities happening in the hospitals, and all of these educational activities focus on the part of knowledge, maybe skills, maybe attitude, but at the end it's already there. And the healthcare staff in general already collaborate and coordinate together to prevent the pressure ulcer. And all these educational programs say that we are aiming to reach the pressure ulcer or prevent the pressure ulcer that we already know it's already prevented. So what's the problem? Why the pressure ulcer is still happening? We come here to the most updated systematic review that try to answer this particular question. And I think this study will open the gate for further understanding and awareness about the challenges happen on the micro level. Regarding to the policies, internationally we have agreed guideline. Let's say that this is agreed guideline. Regarding to the national level, in Jordan, in Saudi Arabia, in Egypt, in China, in Turkey, we already have like a national protocols and agreed among the experts to prevent the pressure ulcer. But even within these situations, within this idea that we have some challenge about the ability to transfer what's already written in the protocols to be coming on the real practice. This systematic review, which is one of the most higher level of evidence, and create further understanding or awareness about barriers and facilitators that prevent the healthcare providers, mainly in the hospitals or in the nursing home, as they already include in some studies, to prevent the pressure ulcer. Why the pressure ulcers still happen? While we already have a proper good level of knowledge about the ability of the nurses to prevent the pressure ulcer. This study just already published soon. That's why I announced about this webinar, because directly when it's already come to me, it's really something magnificent evidence about the role and the challenges that we as nurses and all as healthcare providers faced while they already transfer what they know to the bedside. The study already published in less than 1 month, and since already published, we announced about this webinar about its value of having and discussing this systematic review. As you know, systematic review, it's something unique in the context of academic writing. They collect and analyze bunch of studies, and they already select layers that already create and give you a part about the importance of the conclusion or the findings that they have. So the systematic review will be so much strict, and they answer the question that we are looking for. So the purpose of the systematic review is systematically synthesize the research evidence, and they ask about two aspects only. What are the barriers and facilitators for the pressure ulcer prevention? What make the people ready to prevent pressure ulcer, and what make the people unable to prevent pressure ulcer? Because we already agree about that we did everything. I was consultant before in some hospitals, and they said, we make education, we make training, we have a proper number of nurses, and they already show me the number. At the first point, they have, like, for one nurse already responsible about 6 patients in medical wards, and they increase the number of nurses until they reach to 1 nurse to 4 or 3 in some cases. But the pressure ulcer level still, it's fluctuated, it's in the same level. So, and we do the education, we do the skills. So how we will understand this strange phenomena until we will reach to prevent the pressure ulcer? This study already systematic review, and they apply some parts of the meta-analysis. So it's really a high level of evidence. This study already registered in 2018. So it takes from them around 5 years until they already finish this report. And this the report of the registration in the PROS Bureau. And this, like, when someone would like to start to work on the systematic review, just to make the evidence clear, they should register this, their own protocols, guidelines, and so on, so we can judge their own work and follow up their work. And since the first time, they were looking to review these 2 questions. What are the factors that hinder the implementation of research evidence to prevent pressure injury? And what are the factors that facilitate the implementation of research evidence to prevent the pressure ulcer in hospital settings? So these are their own concern. And I think anyone already work or involved in pressure ulcer prevention, either as a wound care, or either as a nurse administration, or as hospital administration, or as a doctor, or as a quality staff, this question can come to them. Why this happened? The study, already the types of study, they focused on either qualitative or quantitative, and they take the mixed method, and they make it strict that they will revise the last 15 years from 2003 until 2018, and they will refuse to take any editorial or opinions. They're just looking for studies, either qualitative or quantitative, within the last 15 years. The participants and populations, they take all the healthcare professions that already work in hospital, either doctor or nurses or physiotherapists or anyone involved in this process about the pressure ulcer prevention. The focus or the intervention or exposure, they were looking for studies that report barrier and facilitators to pressure injury prevention. I wanted to make it clear for you, many hospitals, and even within these studies, you will see a research report come from hospital A, and it's already published, let's say in the United States or in UK, something. And they apply some intervention like education, some sensory, they put some device on the patient, they change the type of mattress, whatever. And after 6 months or 8 months, another study come to the same hospital, and they discover that the people come back to their own previous stage. That means the intervention that already applied was not sustained. So why the pressure ulcer is not apart from the culture within the hospital? They investigate the barriers that make this to happen, and already would like, or they investigate the hardness of implementation of these interventions. Why the healthcare providers, they will be much more comply with the standards of the pressure ulcer prevention in a period of time, and after that this already declined. Now, maybe someone say that, no, this has happened for all intervention, but we did not see the same for the hand hygiene, for example, compliance, or for medication administration compliance, or for admission and discharge compliance. So what are the uniqueness happening among the issues of the pressure ulcer prevention? They extract the data and they have, sorry, they extract the data, they remove the duplicity, and they focus on the abstract, and they use their own strategies for checking and review the context of the study. The data that already they check from the studies extracted by one reviewer author, and they include even the pre-pilot studies and the pilot studies by the second reviewer, and they focused only on the pressure ulcer prevention. They did not discuss even the pressure ulcer treatment. They use the techniques, we call it theoretical dominance framework, or TDF. And this TDF, for the people who doesn't know, that TDF, it's 14 theoretical domain, can be used to examine the determinants of professional behavior change, and in turn inform intervention development. Each extracted variables, they'd like to understand or ask, is this responsible for or not? This is the TDF, for further explanation. We will come to say, for example, if the doctor evaluates the patient in an OPD, did he evaluate this patient based on his knowledge, based on his skill, based on his social professional role, based on his beliefs about the capabilities, and so on and so forth? And even if there are more than one reason among these 14 reasons, we will say that which one is the most important. For example, maybe one patient come to the orthopedic doctor, and the orthopedic doctor said, okay, you have diabetes, so I will refer you to medicine, to specialists, other specialties. Now, based on that one, why he did not go? Because about the beliefs of the capabilities of the doctors in following up this case. So in this way, we understand why the professional behavior go in this way. For example, you come to say that patient already getting arrested, asystolic. So you will start to do something based on one of these 14 reasons. But this is the TDF. They revise the behavior of people in prevention of pressure ulcer based on this 14: knowledge, skill, social professional role and identity, belief about capabilities, optimism, belief about the consequence, reinforcement, intentions, goals, memory, attention and decision process, environmental context and resources, and social influence, emotional and behavioral behavioral regulation. Now, the good part about this study, that usually we know about the educational system or change management of the people behavior in the pressure ulcer prevention, and we just think on the knowledge, skill, and attitude. But based on this focus about the TDF of the studies, we come to conclude, or they start to build further understanding about the ability of healthcare providers in general to prevent the pressure ulcer from the professional dominance framework, as the knowledge effect, but it's the knowledge part from other 14 parts. Skill, it's part from 14 parts, and so on. And the new rules about further effects come to appear as we will come in this study. In general, the TDF already identify potential barriers and facilitators to behavior change, and to design the intervention to target specific dominance based on this TDF idea about the way that the nurses or the healthcare providers in general perform their own routine tasks. Or the problem in these types of tasks that it will be converted to being something routine. For example, the physical assessment for the GB doctor, it will be routine at the end. So the people will be much more poured and start to ignore the routine tasks. For example, the medication adherence, If we will come to the medication protocols, we know that there are major and minor steps, and they discover that when the people start to take it as a grant, or they will much more close to ignore the tasks, and this ignorance will come because their own belief in their own capabilities will be high. That I'm always giving the medication right, so why I should recheck and check and recheck while already I'm trust in myself, for example. This is just only for you as an example about the applicability of the TDF or our understanding for the TDF. Anyway, they have a strong search strategy for these studies. They already revised really more than 78 studies already passed through the analysis as will come. So it's really a huge amount of data. And this data already comes from all over the world. So we understand their own strength and efforts, efforts to work and check about all the studies already published, and it takes a long period of time. They exclude some special ways or some special units or healthcare facilities, such as the nursing homes, long-term community care settings, because they were looking for the places where the interprofessional cooperation can happen. So in some hospitals or in some institutions, such as long-term community hospitals in America or nursing homes, it's already led by nurses. So there is no other professional cooperation can occur while only one professionality happens. The quality assessment, as you can see here, they already start by around 9,631 study, and they make this the Prisma chart until they end by 78. So really, you will come to say that how much the value of these 78 that's come from 9,600 study, and these studies how much already can read us or teach us about the compliance of the pressure ulcer prevention. This is apart from the quality assessment, and any poor study they already reject. You can see that this is for qualitative, this is for quantitative, and the majorities of evidence come from the quantitative, and you can see that this is the level of the strength of the studies, and it's a different points, and if they already match these points or not, and you can see that the level or the strong part of the studies. For the result, what did they discover about the behavior of people to prevent pressure ulcer? As you know, they discovered part of the knowledge regarding to pressure ulcer prevention. If they don't know, they will not prevent, right? If they don't know the pressure ulcer, the meaning, so this will support our efforts in making the education, in spreading the knowledge. But the good news that they discovered that the general amount of knowledge that the nurses have within the time already increased in the issues of the pressure ulcer, and this is something good, as they already include and support adding the parts of the wound care and the pressure ulcer prevention apart from the bachelor curriculum, and this is also something good, and we want to reach or reach to this level, but it's not significant impact on the performance. They discover that the role of skills in change the way that the people already behave higher than the role of knowledge. If I will make now a pressure ulcer prevention class, I will not focus more on the knowledge rather than the skill getting higher impact by teaching the people or demonstration or hands-on education in the compliance for the pressure ulcer. And this is something good because we already close to make the education by just make the staff to come in one room and make lecture about the importance of repositioning. But in this study, they highlight that make the hands-on much better than making a lecture about the repositioning or about offloading. The significant part regarding to the third aspect of finding about the social professional role and the identity. The nurses, mainly for the nurses, they already change their own way of performing the pressure ulcer prevention based on their own social professional relation in the unit. As when the reposition, let's define what is the reposition. The reposition, that means there are two nurses agreed on the same time to do the same intervention for the same patient. So this study highlights that by default, we should work and support the social professional cooperation between the nurses to perform the pressure ulcer prevention. So making the team spirit, making the impact of the teamwork, it's clearly evidenced by the pressure ulcer prevention. So this also something that maybe the people who are already involved in making the education in the pressure ulcer prevention did not focus a lot about its impact. When the health professions perceived that their pressure injury or pressure injury prevention is not on their primary rules, especially when they have completing priorities about the other task of the others to help their own colleagues. So the believing about the importance of the pressure ulcer and apart from the people identity about what they should do and prevent as apart from the whole consequence of the unit. If the medication error, لا سمح الله, if the medication error happen, we can directly link the one who already make this incident with the medication error, right? So you did this medication, you give this medication. So directly I can link. The problem in the pressure ulcer prevention, we cannot directly link because maybe one nurse will skip the reposition during one shift, but the pressure ulcer that we will discover it maybe will happen after 2 or 3 days. So it will not be easy for us to link. That make part from the feeling of a free responsibility, and this is what they already discovered. And the importance of social influence between the nurses and between the nurses and other healthcare professions and even the family. That when we already make, they found in one of the studies that when we have a good nurse to doctor relation, the pressure ulcer in that unit decreased. So what is the connection? There are something, it was not clear in the picture before about the caring attitude of nurses toward the doctors, toward the patients, and this influenced by their own relation between the nurse and doctor. Now, we are not saying that is it apart from ethical or unethical. We know that this is what happened. This is what the studies already found, and this part from something that we have to work and change our mentalities about. So, in general, when we come to say about the pressure ulcer prevention, we are looking to say performance of art rather than it's a performance of comprehensive system. And the new findings now start to think beyond the patient aspect, and this is what we expect to see in the new guideline. Maybe it will come within 4 or 6 months or 8 months, the new guidelines, and we will start to predict that the international focus about the pressure ulcer prevention will focus not only on the patient and the nurse-patient relation, rather than on the patient organization relation. And this will be open or required from us to be prepared, to be ready, and expect that this situation may be transferred to the accreditation bodies, to the universities, to the authorities, maybe Ministry of Health. We didn't know until now this change will happen until where we can lead. And also, we will stop to blame the people about developing pressure ulcer on their own department or unit, while we have further evidence about something that we did not think about its impact or significant influence on the nurses' prevention of the pressure ulcer. And we are really appreciating your presence and your coming to this meeting. And it's already open for any question or concern, and thank you very much.